Good morning, everyone. My name is Yanisa Samakarn, and I am from the Faculty of Medicine, Chiang University. Imagine a threat in the very air you are breathing right now, powerful enough to cause lung cancer. Today, we will explore how PM2.5 may be silently shaping our health in ways we're just beginning to understand. As you are aware, northern Thailand has been experiencing dangerously high PM2.5 levels. PM2.5 is particulate matter less than or equal to 2.5 micrometer in diameter, which can penetrate deep into our lungs. Exposure to PM2.5 has been associated with negative health outcome, including an increased risk of developing lung cancer. Our focus our focus is on polycyclic aromatic hydrocarbons or PAHs, which are compounds embedded in PM2.5. This compound originates from various sources, for example, industrial exhaust, vehicle emission, biomass combustion, and cigarette smoke. The International Agency for Research on Cancer classified PAHs into four categories based on their carcinogenic potential. For example, benzoapyrene or BAP is a well-known class 1 carcinogen. In northern Thailand, data from 2019 identified BBF, DBA, and IND as the most abundant PAHs in the atmosphere. In vitro studies found that PAHs are procarcinogen that require metabolic activation. Cytochrome enzyme metabolize PAH into reactive intermediates, which bind to DNA, forming DNA adducts that promotes carcinogenesis. Each PAH forms its own DNA adduct. For example, BAP metabolizes into BPDE, a well-documented human carcinogen. Research has shown that PAHs accumulate in lung tissue over time. Furthermore, in 2023, Chiang found that biotransformation of PAHs has been shown to occur in lung cancer tissue. This finding highlights the presence of PAHs in both lung tissue and PM2.5. However, this leaves an important question. Can we establish a direct proof linking PM2.5 exposure to the development of lung cancer? Our research addressed three knowledge gaps. First, there is limited understanding of the difference in accumulated PAHs in lung tissue between lung cancer and non-cancer patients. We hypothesize that carcinogenic PAH will be predominate in lung cancer patients. Second, we wanted to see the relationship between accumulated PAH and PM2.5 in northern Thailand, which might have similar pattern. Lastly, the link between accumulated PAHs and DNA adducts in lung tissue is not well understood. We hypothesize that DNA adducts specific to carcinogenic PAHs will be more prevalent in cancerous tissue. Our study is a cross-sectional observational study. Participants with prior cancer treatment were excluded. Tissue samples were classified by pathologists, and there were no statistically significant differences between baseline characteristic of participant, and the confounding factor will be adjusted before data analysis. Lung tissue samples were surgically collected and immediately frozen. Then PAHs were extracted and analyzed using chromatography to detect 16 priority PAHs. And in the next phase, we will analyze the DNA adducts. For the result, in lung cancer patients, normal tissue show highest level of PAHs, followed by paracancerous and cancerous tissue, while non-cancer control had the lowest. In cancerous tissue, carcinogenic PAHs were 1.14 times higher than non-carcinogenic PAHs. Among this, DBA had the highest concentration, whereas BAP accounts for only 7 to 9% despite its higher carcinogenicity. The unexpectedly low BAP level prompted us to examine its metabolism. In cancerous tissue, the upregulation of BAP metabolism may have been what caused the reduced BAP level. The next step will be to analyze BAP-specific DNA adducts. If these adducts are elevated, it will support increased BAP metabolism. In contrast, the higher level of PAHs in normal tissue likely reflect retention of their original form before potentially undergoing biotransformation. Multiple regression analysis adjusted for confounder, including age, smoking status, mass usage, occupational environment, reveal interesting patterns of two PAHs. BBF, a class 2A carcinogen, was found to have significantly higher level in normal lung tissue of cancer patients compared to paracancerous and cancerous tissue. This could be explained by its increased metabolism into downstream products similar to BAP. As previously mentioned, BBF was found to be most abundant in PM2.5. It is also known to originate from biomass burning. This aligned with our diagnostic ratio assessment, which suggested a pyrogenic source. I1E was found to be higher in non-cancer control than lung cancer patients. It is hypothesized that IND stability as a PAR may have limited its metabolism in non-cancerous tissue, leading to its accumulation. Additionally, diagnostic ratio is a tool helping identify the source of PARs and determine whether the source of PAR is pyrogenic or petrogenic. In our study, we found that the source of PAR was most likely pyrogenic. In conclusion, PARs embedded in PM2.5 act as pro-carcinogen. Normal tissue in cancer patients had the highest total PAR, possibly due to accumulation and potential for biotransformation. Carcinogenic PAR found to be higher in cancerous tissue than non-carcinogenic PARs, supporting a link to carcinogenesis. BBF, the most abundant PAR in atmospheric PM2.5, shows significantly higher accumulation in lung tissue of cancer patients. And finally, diagnostic ratio suggests the possible source of accumulated PARs to be pyrogenic. The next step of our research is to prove that diminished level of key carcinogenic PARs in our lung tissues are linked to an increased expression of PAR-specific DNA adducts, which could help confirm the correlation between PARs in atmospheric PM2.5 and lung cancer carcinogenesis. Thank you for your attention.
Thank you for valuable information from Ms. Yanisa. Do you have any comments or any questions?
Okay, thank you very much for your very nice presentation. So I have a question on your how you include the sample into the study. And what kind of sample that you use to analyze for PAR?
We use direct lung tissue. There was 3 lung tissue that we are included, which are normal lung tissue, cancerous tissue, and the paracancerous tissue. We included the patient from patient who already was diagnosed with lung cancer, but needed any need to open the lungs surgery for like diagnosis or other things. So if they don't have cancer, there would be other indications that they needed to be surgically corrected. So we took out their samples and then we just included them, and the exclusion was as presented.
So it's fresh tissue, right? When you got like biopsy.
Also, the patient would have to stay. Yes, it is fresh tissue, right? Yes, exactly.
Okay. So the inclusion criteria, so those, especially for cancer, they need to expose with PM2.5 or not?
Yes, that's right.
Okay.
They are exposed to PM2.5 because since we are also collected information about whether they're working outdoor, indoors, whether they have air purification at home, if they're using their mask. Yes, but mostly of population in northern Thailand will be exposed to PM2.5 no matter what. Yes.
Okay, thank you.
Okay, thank you for presentation. I would like to ask about the conclusion that you given at the second bullet. You are saying that PAR is the causative of the cancer. So could you try to explain again how can you conclude that from your research design?
So I don't think we can say that it's a causative factors that causing lung cancer since it is multiple factorial disease, but we can say that it's contributing to the carcinogenesis of lung cancer. So to conclude, I don't think we can say right then and there that it is causative, but it is definitely doing something to our lungs and contributing to its carcinogenesis.
Did you determine the DNA at the duct or not? And what the result?
We have, yes. We have not yet determined the DNA adducts. That will be in the next level. Since this is a very new things in Thailand, there have not been anyone else who done this before. We are developing the techniques right now. And also past extraction is also a new technique